Yes. Right.
So Dr. Pirzad is there? Professor Pirzad? Anyway, I think we can start, Professor Yokokato. Sure. Then, hello, good morning, good afternoon, and good evening to our distinguished speakers, chairs, and audiences of ACNS YNS webinar from different parts of the world. We are back again with yet another session of educational lectures for you to promote the neurosurgical education in the low-resource countries, especially this time we are doing for Myanmar and Afghanistan. Today we have invited speakers for today are Professor Marcos Tatagiwa from Germany and Professor Tadashi Watanabe from Japan. And we have YNS speaker, young lady neurosurgeon from Egypt, Dr. Heba. Along with that, we have our chief patron, president of ACNS, Professor Yoko Kato, and our co-patron, Professor Fawad Pirzad, who is the president of Neurosurgical Society of Afghanistan. Unfortunately, because of the poor internet connection, Professor Matthew, the president of Neurosurgical Society of Myanmar, is not able to join today. On behalf of ACNS YNS committee and Professor Yoko Kato, we welcome all the speakers and audiences to this educational online platform of ACNS YNS webinar. Today, the moderator, along with me, Dr. Liu, who is the chair of ACNS YNS committee, Dr. Chen Chuya, she's a member of ACNS YNS, and young lady doctor from Afghanistan, Dr. Rihanna, is there. So, with that short introduction, if may I ask Professor Yoko Kato to give some opening remarks, and then we'll start. You have to unmute, Professor.
So Professor Tatachiba is the giant of the skull base, maybe not only the skull base, but also the whole, the entire the neurosurgical giant, I think. So thank you very much for giving us your great lecture, even your hectic time. So just you can enjoy. We invited the young neurosurgeon from especially the developing countries. So it is as the ACNS our role and wish. So just maybe a bit slowly and a bit easy from the basic talk, please including. And second speaker is of course already Sachin. He introduced Dr. Watanabe is another giant of the endoscope. Recently, he never used the microscope, only the pure endoscopic surgeon. Maybe he will introduce the whole and the neurosurgical region treated by the pure endoscope. And third one is a female neurosurgeon from Cairo University, Dr. Haber. She is a very promising female neurosurgeon. She can be the leadership of the female society, I think, in the future. The chairperson is the Chen is very active, the Chinese lady neurosurgeon. She already contacted with Dr. Ghafari from Afghanistan already. Maybe she can report a little bit later, I think. So we wish your very nice presentation. Thank you so much.
Thank you. Thank you very much, Professor. Professor Fawad Pirzad is also there. Welcome,
yes.
Professor.
Hi, Pirzad.
Hello.
How are you?
Hello.
Hi, how are you?
Konnichiwa. Hello. Good morning.
Hello.
Salam alaikum. Salam alaikum for everyone.
Salam alaikum.
Good afternoon.
Thank you for joining. So with that short introduction, let me introduce our first speaker. Professor Marcos Tatagiba is currently the chairman and director of the Department of Neurosurgery of University of Tübingen, Germany. He's finished his medical study at the University of State of Rio de Janeiro, Brazil. and then neurosurgical training at Department of Neurosurgery, Klinikum Hanover, Germany, under the chairmanship of respected Professor Majid Sami. Then he finished his Board of Neurosurgery in March 1993 with German and European certificates. He's got many major prizes, and among that, the most famous is Young Neurosurgeon Award of WFNS in 1997. The European Association of Neurological Surgeons Oscar Prize Award in 2001. He's the president of German Skull-Base Society in 2014 to 2015. He is the head of International Affairs, German Society of Neurosurgery, and member of World Academy of Neurosurgical Society. Along with that, he's a member and honored member of further 20 national and international societies, and he's the author and co-author of 410 peer-reviewed articles, 10 books, and 35 books chapters. So, like his mentor and his teacher, Professor Majid Sami, he is also excelled in the skull-base surgeries, and today he's going to talk with us about the tips and tricks in retrosigmoid vestibular schwannoma surgery for the young neurosurgeon. Over to you, Professor Marcus Tatagiba.
Thank you very much, Dr. Saking, and my dear friend, Professor Yoko Kato, for this introduction and for the organization of this very important webinar. And I'm very glad to see people from different countries. Not every time easy to do neurosurgery in many areas of the world. And even more important, to try to give a lecture which is not so much sophisticated, a simple lecture, but showing what we can do in this special case of vestibular schwannomas. I would like to share with you our experience regarding indication, surgical treatment, and at the end, I will give some information on comparative study between Gamma knife and surgery for vestibular schwannomas. I guess most of you don't know where we are located. So the city of Tübingen is a small university town with just 80,000 people living here in the middle of the state of Baden-Württemberg. So Baden-Württemberg is one of the south states in Germany. Bavaria, you know, very famous for the beer, for BMW, for Bayern Munich, and so on. And in our state, there are many strong companies which work for medical instruments like Esculap, Storz, and many others. And this area is a beautiful area surrounded by forests, the Black Forest, very famous one, a lot of castles. And the university was founded more than 500 years ago. So one of the first universities in Germany. And the hospital is more than 200 years old. And nowadays, of course, is a modern facility. And different people arose from this university, like astrophysics Kepler. Alzheimer was medical student in this university, this medical university. And you know, the former Pope, Benedict, he was teacher in this university as well. So to have an idea where we are located. And let's come to the vestibular schwannoma, our topic today. Although vestibular schwannoma is almost always a benign and I would say almost boring histological tumor, and it can appear very differently in different situations. And depending on the appearance, you will have a more difficult or an easier treatment. So you see here, this is a large tumor, but with regular borders and not growing into the interauditory canal. You can even see facial cochlear nerve here. This tumor is more likely to be removed completely with preservation of facial nerve and even preservation of the cochlear nerve. This tumor here, although it's approximately the same size, but it's completely different situation, growing into the internal auditory canal, very irregular borders. Here is even preservation of the facial nerve more difficult. So we cannot really compare both, although when we do analysis, we say, yeah, 2.5 centimeters, but they are completely different. And these large tumor, so here we have to save life of the patient. Of course, we fight for the facial nerve as well. Sometimes we have to do incomplete removal in order to preserve the facial nerve. Bilateral vestibular schwannomas, it will be presented later on in a case, as I've heard. It's a completely different situation. I will not talk on this topic today because it's a completely different thing. If you want, in another opportunity, I can give a lecture on neurofibromatosis. This is one of our strong topics in our center. We have a center for neurofibromatosis here. And you see, cystic vestibular schwannomas, they are different as well. So this capsule used to be very much attached to the pia mater of the brainstem, the vessels and nerves, and sometimes we cannot remove this teeny capsule without producing problems. So same tumor, but completely different. We know that the growth rate of vestibular schwannoma is very low. Usually, these tumors grow in average 0.5 to 1 millimeters per year, and it needs 4.5 years to get double in volume. As you can see here, 2002 and 2018, almost the same thing. This is an extreme case where the tumor didn't grow, but you see, it happens. That's the reason why if we get this image, we should not go immediately for treatment. It's worth it to wait and observe the tumor for a while. But there are cases like this as well, 2005 like this, 2008 much bigger. So we shall not wait 3 years until we will do the next control. Our protocol is to perform the first MRI 6 months after the first one, and then every year to control the growth rate. So because of this behavior of the vestibular schwannomas, we may have different options of treatment. So observation is the classic one for small tumors, and radiosurgery or radiotherapy, you see different types, more likely to be used in small tumors. Microsurgery, different options as well, more likely to be used for large tumors or small tumors in young patients. And of course, chemotherapy doesn't play a big role, only in cases of neurofibromatosis type 2 with the use of bevacizumab. In our series, we could not see any influence of aspirin in the growth rate of vestibular schwannomas. So the classical indication for radiosurgery, in my opinion, is this one. Older patients, 69, with a small growing tumor. If the tumor is not growing, don't do anything. But if the tumor is growing and patient is older, then this is, in my opinion, a good indication for radiosurgery, although there are still some patients who refuse radiation and wish a surgery, so you have to discuss with them. Classical indication for surgery, despite this small size, is the young age. So if we have young patients with a small growing tumor, we do not recommend radiosurgery. Our first choice is surgery. In case that the patient is refusing surgery, then the second option would be radiosurgery. This is our protocol in our department. I used to say radiation is better than a bad surgery, but the radiation is not better than a good performed surgery in young patients. So surgical indication will be classic ones: large tumors with brainstem compression, cystic tumors, because they do not respond well to radiation. They are unpredictable and can grow very fast. That means they can increase the volume very fast because of the cystic component. Young patients, or if they have strong vestibular-related symptoms, the patient will benefit from a neurectomy of the vestibular nerve instead of radiation. In bilateral vestibular schwannomas, we are in favor of early surgery to open the internal auditory canal at least, and also to reduce the size of the tumor. But this is a different topic. We may discuss this in another opportunity. And patients' individual decision. As I said, there are patients who refuse radiation, there are patients who refuse surgery, then we have to change the strategy. I'm not in favor to expose the patients all options and then let them alone to decide. I prefer to discuss all options, and then I give my opinion based on knowledge, based on experience, and then I give a recommendation to the patient, which is my first choice, the second choice, the third choice. Finally, the goal of the surgery or the treatment, the goal of the treatment will be to cure or stabilize the disease and preserve quality of life. And to achieve these goals, we may use surgery, radiation, or sometimes observation. Maybe some of you have read the IANO guideline for vestibular schwannomas. There are several points I fully agree. First of all is that there is no strong evidence in controlled clinical trials which treatment is the best one in which case. So we have to really individualize the decision. And summary of the recommendations in this paper was that MRI with gadolinium is the gold standard diagnostic procedure. Histological verification is not always 100% required. You can treat a tumor, for instance, with radiation without having the histological proof that this is a vestibular schwannomas. And in general, we are in favor that these cases are discussed in a broad tumor board in order to select the best treatment option for the patient. And because this is a sophisticated skull-base tumor, we are in favor that treatment is done in large volume centers and not just once per year in all departments in the world. We are, however, not very much in favor of the decision of this guideline that small tumors all must be irradiated. In my opinion, young people must become the chance to be cured of the disease with a good surgery. In order to perform preservation of the function, we used, of course, intra-op monitoring. And I would like to highlight these basic ones: sensory evoked potential, also motor evoked potential of the arms and legs in order to prevent any kind of paraplegia during the position of the patient, facial EMG and also facial MEP. So we stimulate the motor cortex and capture the EMG response at the face, and auditory evoked potentials. We can also use the continuous stimulation of the facial nerve at the brainstem. This is a useful procedure as well. Our Japanese colleagues use a lot this kind of procedure. The only disadvantage is you have to find first the facial nerve before you do it, because you need the facial nerve in order to produce this stimulation. With facial MEP, you don't need to find the facial nerve. You can stimulate at the motor cortex and you have the response all the time. The other point is, in very large tumors, we can perform monitoring of the lower cranial nerves in order to avoid any stress for the vagus and glossopharyngeal nerve in giant vestibular schwannomas. And finally, auditory evoked potentials for patients with preserved hearing preoperatively. And we have to observe the waves 1, 3, and 5, basically, in order to check whether hearing is preserved. In some special cases where patient can hear, but auditory evoked potential is very bad, we can use the directly recording on the cochlear nerve. You see here one example. Auditory evoked potential doesn't show good waves, but the direct recording will show much better waves. So these can be used in special cases, but you need to expose the cochlear nerve as well. So regarding the surgery strategy, there are 3 basic approaches: middle fossa, translab, and retrosig. In the past, where microscope was not very much developed, these both approaches became the most important approach, mostly used by ENT colleagues. But since the microscope became a strong tool for neurosurgeons, retrosigmoid approach became the most important approach for neurosurgeons, because it gives the opportunity to remove tumors in all sizes, and at the same time to give the chance at least of hearing preservation. I don't like the middle fossa approach because it means compression of the temporal lobe. I don't like the translab approach, although this is a good approach, of course, but it takes a long time to perform and the risk of CSF leakage is higher, and we are not going to see the lower cranial nerves up to the end of the surgery. In retrosigmoid approach, we see the lower cranial nerves from the beginning on. So you see here there are MRI papers showing what happens with the temporal lobe using the middle fossa approach for vestibular schwannomas. You see these changes can produce cognitive disturbances, mood changes, and even epilepsy. And Professor Daraf and his group has shown many years ago that indeed one of the causes of cognitive disturbances and depression in vestibular schwannoma patients was the use of middle fossa approach. We have done more than 1,600 vestibular schwannomas surgeries in our department, all of them performed with the retrosigmoid approach. So for small tumors like T1 and T2, I use the supine position with the head turned to the contralateral side. For large tumors, I use the semi-sitting position. But this is the correct semi-sitting position. You must pay attention that the legs are not positioned too low, otherwise you will get air embolism. If you position the patient like this, and the patient is not dehydrated for any reasons, the risk of air embolism is nearly zero. So this is what we have shown in our studies we performed in this department. And there is this randomized multicenter trial in Germany, was published in 2019, that compared the semi-sitting position and supine position in vestibular schwannoma surgeries. And what we saw was that in semi-sitting position, the rate of total tumor removal was higher. The surgery was faster, and facial nerve results were better. You see here, 1 year after surgery, you have better Haus-Breckmann 1 and 2 than in using supine position. And our evaluation of the risk of air embolism for using semi-sitting position has shown that you may have some bubbles detected at the transesophageal echocardiography, but no patient, absolutely zero, had at any moment during surgery instability. And this is analysis of almost 1,000 patients. So regarding the approach, retrosigmoid approach, let's concentrate to this approach. This is the right way to perform the retrosigmoid approach. The retrosigmoid approach is as important as the pterygonal approach. This is the pterygonal approach of the posterior fossa, I may say. And the right way to do is to expose the inferior border of the transverse sinus, the lateral border of the sigmoid sinus. It's not necessary to skeletonize the sinus. This part here is extremely important. You may not leave any remnant of bone blocking your view. You must take bone up to the skull is becoming horizontal. It's not necessary to open the foramen magnum, but the skull base must be plane, must be horizontalized in this craniotomy. And the medial limit, it's about 2.5 centimeters here. When you have opened the head, and then you can cut the dura in a line incision. Some people do a flap incision, that's okay. I personally prefer one straight incision at the dura mater here. It will make the suture, the closure later on much easier. And you see when you have opened the dura, then you have this appearance. Of course, you have a tumor here inside, but this is the anatomical view of this area when you open the dura. You have the 7th and 8th nerves, intern auditory canal. Then we have the jugular foramen with glossopharyngeal nerve, vagus nerve, 11th nerve, pica. Ica is not showing well here. And look, this is the correct way to put the spatula. This spatula is not real a retractor. It's just holding the cerebellum so that the cerebellum is not falling down. So we are not compressing the cerebellum with this spatula, okay? Again, opening the craniotomy, dura incision, and then we have this area. And the way to approach is from below to above. Look that the spatula is more opened at the inferior part than at the superior part. This is to avoid retraction of the Dendis vein, of the petrosal vein, so you avoid a rupture of this vein, which might produce problems in some cases. So when you put the spatula, please hold the cerebellum at the inferior part more than at the superior part. I hope you could get the message. And then look at the anatomy of the dura at the petrous bone. If you observe the anatomy of the dura, you will see that at the inferior part, you have these dura lines, these rings of the dura here. They all end at the same line, okay, at the same point. If you trace a virtual line here, this line will represent the inferior border of the internal auditory canal in nearly all cases. This line we have described and we call it the Tübingen line. Then you open the dura in this way, okay? So this is the inferior border of your dura cut, and you cut the dura in this way. If you do it, you will not miss the internal auditory canal, even in large tumors. Then you open with a diamond drill, try to open the canal 180 degrees so you don't have bone hindering your view. Then you can start the tumor resection with the internal auditory canal to have a distal control of the facial and of the cochlear nerve. And this is just a very short video showing this technique. You cut the dura here like that, then you can drill the internal auditory canal. Once you have done it, then you start the dissection of the tumor from the nerves at the internal auditory canal. Some tumors are growing very far up to the fundus. Some are not doing that. If the tumor is not growing too far inside, it's better, of course. And then When you have done this job, then you can come to the CP angle. And look at the retrosigmoid approach. You see the lower cranial nerves from the beginning on, which will give a better chance of preservation. So again, internal auditory canal first. The point is, if the patient has hearing and you don't want to injure the labyrinth block and produce inner ear hearing loss, then you have to leave some piece of the bone here. Otherwise, you will cut the semicircular canals. So, but if you do that, then you have a blind area here. In order to overcome this difficulty, you can use the endoscope. With the endoscope, you are going to see the fundus of the internal auditory canal in order to make sure that you have removed the tumor completely. So the use of the endoscope in retrosigmoid approach replaces completely the advantage of middle force approach in terms of showing directly the fundus of the internal auditory canal. Now, a video of a small tumor we have done in supine position. The first step is to open the system. Don't put the any retraction without opening the system. If you open the system, cerebellum does not need to be retracted, can be held with a spatula or not. I prefer to put a spatula to protect the cerebellum. Then you cut the dura at the area I told you, at the Tübingen line area, and then you can start drilling the internal auditory canal. You start with, I start with 3 millimeters diamond drill, then I change to 2 millimeters, and finally 1 millimeter to do the final work. Okay, let's come up to this part. So internal auditory canal has been exposed widely, 180 degrees. Then we can cut the dura mater of the internal auditory canal. Okay, you can do like this. And then you will start the removal of the content of the internal auditory canal. Okay, I'll go a little bit faster. When you have done it, you have debulked, then you can use the CUSA as well. Even in small tumors, you can use the CUSA carefully to decompress, so you avoid manipulation of the nerves. And then we separate the facial nerve upwards. The facial nerve is located at the upper part of the internal auditory canal. The cochlear nerve is usually at the inferior part of the internal auditory canal. And we started the dissection firstly from the brainstem to lateral, and then from lateral to brainstem to finalize the work. So again, superiorly is the facial nerve, inferiorly is the cochlear nerve. And then this is a good way to dissect the structures. You can hold the tumor with one hand, and with the other hand, you can separate the arachnoid and the perineurium of the nerves in order to get the tumor completely removed and preserve the nerves. Okay, so this is the way to do that. This is the technique that has been propagated and popularized by Professor Sami, and we use here in our department as well. So when you have removed the tumor, you see petrosal vein is preserved. Then you can enter with the endoscope. You see we had a high jugular bulb in this case. We skeletonized the high jugular bulb. Then you can watch into the fundus. You see the transverse crest separating the facial nerve from the cochlear nerve. The transverse crest separates the facial nerve superiorly from the cochlear nerve inferiorly. And another advantage of the endoscope is to show these teeny air cells you see here that can be opened during surgery and will cause CSF fistula if we do not recognize and close it. And under the microscope, sometimes we cannot see that. We have a helicopter here in the hospital bringing any accident. Apologize for that. And so now we can use the, at the end, muscle and fibrin glue. Okay, so, and this is the CT scan later on. So now I would like to show you another case. This is a younger patient, a lawyer, who wanted to get married and have children. And she said, no radiation, please. I wanted to have this tumor removed. I'm too young for radiation. So we agreed completely with this decision of her. So we did the same, opening the internal auditory canal as the first step, and then removal of the tumor from the internal auditory canal, evacuating everything. Then we can watch inside with the endoscope. There is tumor remnant here. You can see that. So this is the vestibular nerve, which was cut. And then, I don't know why it's, let's continue. And you see here, we have seen under the endoscope, and then we can remove this part with some angulated instruments. And finally, we can approach the tumor at the CP angle, doing enucleation, debulking, and then separation of the facial nerve and the cochlear nerve. You see that this surgery was done in sitting position. You have a clear view. You don't have blood disturbing your view during surgery. So you can identify better nerves, vessels, and it's then easier to perform complete removal and preserve the functions. All the time, auditory evoked potential, facial evoked potentials are being performed. And again, here you see this opened air cell that is closed with bone wax. This is our technique, how to do it. And then finally, muscle and fibrin glue. Okay, so the patient had preserved hearing after surgery, and this is the patient immediately after surgery. And later on, she got a baby, got married, and so on, and she was happy. Maybe because of time, I will not show this other case. I will come forward. You see, this was a larger vestibular schwannoma, also with preoperative hearing. We did near total removal. You see here very teeny contrast enhancement. This is a teeny part of the tumor we left over the cochlear nerve in order to preserve the function. It worked well, and the patient could again use skiing, and she had a good balance. And the publications show that preserved hearing after surgery is likely to stay preserved. Some patients may deteriorate, but most patients will keep hearing preserved. This is the Italian group. This is the Japanese group, showing similar results. Different than radiation, because after radiation, hearing will decrease. After 5 to 10 years, hearing will get lost. And there are, however, some reasons why in some surgeries we preserve the nerve anatomically, the cochlear nerve anatomically, but the auditory evoked potentials get lost after surgery. It's a very sad situation because we have done the best for the patient, but the patient is deaf. Some of these patients will benefit from cochlear implant, that's correct. But if we can find a way to preserve this function, of course, it's better. One of the causes of this phenomenon is vasospasm because of ischemia of the cochlear nerve. In order to address to this topic, we have done a retrospective study in our department using intrathecal papaverine in these cases. So we irrigate the surgical field with papaverine in 1 to 30 solution. We analyzed 103 cases. in 1 year period, we excluded NF cases and patients who have had previous treatments. In 61 patients, there was preoperative hearing. So this was the focus of our examination. We tried to preserve hearing in all of them. In 55 patients, we could preserve the nerve anatomically, but that means in 90% of the cases, we could preserve the nerve anatomically, but function deteriorated with the tumor size. You see, we preserved the nerve, but function got lost, most in large tumors. And the tumor size was similar in the control group and papaverine group, so that means they matched. But you see the difference in function. In the papaverine group, we could preserve the function, so hearing, in 70% of the cases. If we have not used papaverine, we preserved hearing only 50%. And interesting is, we got Gardner-Robertson 1 and 2 in 30% of the cases and in 80% of this group in which we used papaverine. So conclusion was, papaverine seems to improve the chance of hearing preservation. If we come back to facial nerve, then we have following situation. There are large tumors in which we can preserve function perfectly. Like this case, I told you at the beginning, regular borders is a good case for preservation. But even those cases, you see good facial preservation immediately after surgery, despite the size of the tumor. That's the reason we are not in favor of the strategy of doing subtotal removals as a standard in these cases. We try total removal. And you see, in a number of cases, it's possible to preserve the facial nerve immediately and well. But there are cases we have Haus-Brackmann 2 or even Haus-Brackmann 3 after surgery. But the point is, what happens with these deteriorations we get immediately after surgery? You see here, they improve over time, after 3 months, after 15 months. So important is to have the evaluation of the facial nerve over time. You see here, these large tumors, all these patients had immediately after surgery Haus-Brackmann 4, but over time, they developed Haus-Brackmann 2. And these cases, they had all Haus-Brackmann 4, but they developed Haus-Brackmann 1 and 2 over time. So sometimes partial removal is necessary. That's correct. And partial removal is like this: near total, subtotal. You see here, sometimes it's necessary because otherwise we will kill the facial nerve. Or here, older patients. But in general, we fight for the facial nerve. Why? Because if we remove the tumor completely, we will give the patient a better chance of recurrence-free, and we are going to give the patient a better quality of life, according to the paper of the Mayo Clinic 2018. So tumor remnant produces stress to the patient, and the patients may have reduced quality of life. And you see this important paper of Nakatomi 2017 showing that after total removal, the risk of regrowth is much less. You see here, recurrence-free survival is much higher in total removed tumors than in subtotally removed tumors. And finally, this will be my last topic. So complications, we had one death in this series of 1,000 vestibular schwannomas, bleeding that demanded resurgery in 6 patients in 1,000, but without greater relevance. At the beginning of our series, we had 11% CSF leakage. Now with the use of endoscope, we could reduce to 3%. Please check on this paper, this guideline for treatment of large vestibular schwannoma. We published in Acta Neurochirurgica last year. And maybe my time is gone. I will not show the result of this comparative study. If you say that I should continue, I can continue. Otherwise, I stop here and we can go to the other topics and discuss them. What do
you can continue, please.
Shall I continue? Okay.
Yes, please.
So
thanks.
this is a comparative study we have done here in Germany. We compared two big centers. We compared our center, in which we do only microsurgery, with the center of Gamma Knife, in which only Gamma Knife is being performed. Both centers treat more than 100 patients per year. And we checked tumor control, whether the tumor remained stable or not, failure. We checked the hearing, facial function, and other functions. So we excluded an F2. We, of course, you may say, yes, this follow-up is not good enough. That's correct, but it's at least something. We excluded patients having less than 1 year follow-up after surgery and patients having less than 2 years follow-up in radiosurgery. At the end, we had mean follow-up of 4 years in both groups. So we had 427 radiosurgically treated patients and 200 microsurgically treated patients. And you see, tumor extension was small and large in both groups. Surgery treated relatively more large tumors than radiosurgery, but interesting is that also large tumors had been treated with radiosurgery as well. And this was a surprise for us. So let's go to the results. The tumor control was 87% with mean follow-up of 4 years in radiosurgery. So this 13% failure does not mean necessarily that all patients had to be immediately treated afterwards. It means that the tumor presented a growth which was more than the described volume growth you may observe in radiosurgery. So this is real failure. And after surgery, with a mean follow-up of 4 years, we had a tumor control rate of about 96%. So it was higher than radiosurgery. This is not a surprise. After, regarding hearing, according to Gardner-Robinson classification, radiosurgery was better in producing hearing preservation than microsurgery. You see, 60% is not bad, but it's worse than in radiosurgery. This is a general number. But when you divide the tumors into different sizes, you are going to see that in small tumors, the results are very comparable to the results of radiosurgery. You can see here, for large tumors, radiosurgery was much better. But this is the group of the patients which could not be controlled well after radiosurgery. And it's clear that over time, these patients will lose their hearing because tumor will grow and the hearing will deteriorate. With the facial nerve was similar. So radiation was better than surgery in preserving facial function. You see House-Breckman 1 and 2, 93%. This is a good number, but it's worse than after radiosurgery with mean follow-up of 4 years. But again, if you divide the tumors into different sizes, you will see that in small size, surgery produced very comparable results with the radiosurgery. In larger tumors, surgery was worse. But again, this is the group of the patient that cannot be controlled well after radiosurgery. So there is a balance here. Regarding vertigo, surgery was better in producing reduction of vertigo over time, and even in patients who had vertigo before surgery. Surgery was better than radiosurgery in producing reduction of tinnitus, you can see here, in comparison to radiosurgery. And even in patients having tinnitus before. Regarding trigeminal nerve, we could see a difference only in large tumors. I think this is obvious because these tumors are large, producing compression of the trigeminal nerve. Otherwise, there was no difference. And you can see here very little difference, but only in large tumors. So in conclusion of this study, we can say that the control rate in surgery is better. Hearing preservation, facial preservation is better in radiosurgery in general, but not for small tumors. For small tumors, the results, functional results, were quite similar. That's the reason in young patients with small tumors, we go, our preference is to go for surgery, not for radiation. For older patients, radiation is a very good option. I think this is the summary of our study. I hope you could follow step by step, and I do hope that you will become all experts in vestibular schwannoma surgeries in future. Thank you very much.
Thank you very much, Professor. That was definitely an enlightening lecture about vestibular schwannoma surgery for the young neurosurgeon. I'm sure there'll be many questions from the panelists and from the delegates. Dr. Liu?
Thanks, Raja. Thank you, Professor Marcos, for very nice lecture. Professor, I wish to ask, although you didn't present about the bilateral NF2, I still wish to find out from you if a larger tumor site with hearing loss and a smaller tumor on the opposite side with preserved hearing, which would you operate first? My second question, Prof, when you drill the intracanicular part of the bone, do you prefer different type of saline irrigation, whether cold saline and just a normal room temperature saline make any difference to the reduction of the heat injury? My last question, Professor, do you still think that tumor control are equal to near total tumor resection? Because that is the definition by radio surgery. And you did show that the facial nerve improved with surgery are the same thing you observe in radiosurgery. Thank you, Professor.
I hope I could get all your questions. They were very important questions, what you are making. The first one regarding neurofibromatosis. I hope maybe in future I can give a general lecture on that. But if you have a patient with deafness on one side and hearing on the other side, of course, we operate the area with the deafness first, of course. But look, if you have a patient with deteriorating hearing on one side and good hearing on the other side, then we operate the side where the hearing is started deteriorating, and then we try to preserve the auditory evoked potential in this case anyway. So sometimes you have the situation, hearing is good on both sides, sorry, but auditory evoked potential is better on one side. So we operate that side where auditory evoked potential is better because we can monitorize the nerve better. We have done studies, we have published that very recently, that if we open the internal auditory canal and just debulk the tumor a little bit, we can preserve hearing longer than if the patient is left alone, okay? And we have seen that the remnant tumor grows slower than the original tumor. Probably this is because of inflammatory reaction within the tumor and because of devascularization of the tumor. But we have observed this phenomenon. But of course, to make this decision, you must have experience in vestibular schwannoma surgery. We should not touch these patients without experience. Otherwise, you're going to damage them. The second point was, in the past, we waited until the patient had deterioration of hearing, and then we put papaverine. Nowadays, we irrigate everything with papaverine. So we do papaverine every time again. This is hydro dilution, 1:30. We don't wait until there is deterioration, okay? And we try to keep the middle arterial pressure about 90, between 80 and 90. We try to avoid hypotensions, because we have seen many times hypotension produce loss of auditory evoked potentials. And the third question was, I forgot.
On tumor control versus near total resection. Tumor control in radiosurgery versus near total resection in surgery, are they the same? And then whether radiosurgery do give a better facial nerve improvement like you show in your surgery? Thank you.
Yeah. This is a good question. Look, I go maximum. I don't plan subtotal removal. Unless the patient is very old, like this old lady I showed to you, then it was, we planned subtotal removal. Otherwise, I plan total removal, okay? So, and we check how far we can go. And in a majority of the cases, we can remove totally, okay? And we accept deterioration of facial MEP up to 50%. So up to 50%, you are sure this facial nerve will recover again. But if the facial nerve is deteriorating more, then we stop. So these remnant we observe first. I have a number of cases in which this remnant part is stable over years. So I wait. And then it's interesting phenomenon. If the tumor is starting to grow again, some patients ask me to reoperate. The patients ask not to send for radiation. Some of them want radiation. I recommend radiation, but there are patients who refuse radiation and want second surgery. It's interesting because in the second surgery, sometimes the tumor can be easily removed, interestingly, although at the first surgery it was not possible.
Thank you, Professor.
Thank you, Dr. Liu. Dr. Rihanna is there from Afghanistan. She has a question for you, Professor. Dr. Rihanna, go ahead.
Good evening, everyone. Assalamu alaikum.
Yes, hi.
Much, Professor, for the very useful presentation, especially for us young neurosurgeons. I have two questions. One is regarding the DORA opening. You said that we opened the DORA at Tubin line in a straight line. Does the tumor size matter in opening of the DORA? Do we always open it in a straight line, or if the tumor is large enough, do we open it in a U shape or a T shape? And my second question is during the air bubbles. You said that semi-sitting position decreases this complication, but what do we do if it occurs? How do we manage this?
How I manage what? I didn't understand.
I see.
The air bubbles, you said.
Air bubbles. Okay, this is a very good question. I see you are very, very experienced people, so you are making really good questions. So the opening of the dura in our institution always straight along the sigmoid sinus. Okay, but you must keep about 2-3 millimeters away from the sigmoid sinus so you can close it again. So it's always the same. I have learned this from my teacher, Professor Sami, who did always the same. He never used second or third cuts of the dura. So, because these will make dura closure much more difficult. And it's really not necessary. If you do a straight cut, you start below the transverse sinus and you go down up to the end of the sigmoid sinus, you have sufficient space. But provided your craniotomy is correct, the problem is that a lot of people, even in my departments, when the residents are starting, they leave some piece of bone below. And I show them, look, this is very important to remove this bone so that you can approach from below to above, you know? If you don't do that, you are approaching the cerebellopontine angle from above, and then you put your spatula, you have a rupture of the petrosal vein. Then you start your surgery with trouble. So if you go from below, there is no vein on the inferior part. Can you get my message? Yeah. So
Yes,
if you
thank you,
put your spatula there, you have nothing. You have only arachnoid, tumor, and the lower cranial nerves. Then you must pay attention to that. So the point you mentioned with the air bubbles, when you have air bubbles detecting, what you shall do is you ask the anesthesiologist to do a jugular vein compression. Okay? So if the patient is in sitting position, the anesthesiologist, our anesthesiologist, they know already, they say bubbles. Then I do jugular compression. They compress here. This way, the pressure, venous pressure is elevated. And then you see any bleeding coming from the corner, sometimes even with bubbles. Then you put a fibrin glue, and then you can continue your surgery. Okay.
Thank you so much, Professor.
Welcome.
Thank you, Rihanna, for participating in the discussion. Dr. Hitet is there from Myanmar. Hello, Dr. Hitet.
Yes. Thank you, Professor, for the very informative lectures. I'm just very beginner neurosurgeon from Myanmar. So I have one question. You said, you know, in a large tumor, the sitting position is better. You know, can you explain the reason behind, you know, for me, I never seen anybody done in sitting position for the vestibular schwannoma case. So can you explain me? I have seen, you know, like Papen position only, retrosigmoid.
Yes, yes. So the people who started with supine or park bench position and moved to sitting, they confirm what I'm saying. So in sitting position, if the sitting position is correctly done, so you put the patient, then you approach the tumor from below to above. During the entire surgery, your assistant irrigates the field. So your hands are occupied with tumor removal and dissections, and you do bimanual dissections. So removal of a large tumor in our department takes not more than 2-3 hours, because you don't lose time making suctions, looking for areas. You don't have blood accumulated in the field, you know. Maybe in another opportunity, I can show you more videos of large tumors. You will see even in large tumors, you have a clear field, and then you can dissect the structures better, and you can see the structures better. So I really recommend it. And if you have someday after COVID era, if you have the opportunity to come, it will be a pleasure to show to you the technique.
Thank you. Another thing is we have in our country, most of the tumor, they come in a very big one, you know, and some having, you know, really big and the brainstem compression. So how do you manage the brainstem compressions, you know, the section between the tumor and the brainstem?
Yeah, if the patient has hydrocephalus, for instance, before surgery, I used to put a drain. Or you can put a VP shunt, wait 1 week, and then operate the patient. It depends on the situation, how urgent it is. So the point in vestibular schwannomas is within the tumor, there is nothing, you know, different than meningiomas. Within meningiomas, you may find vessels, nerves, it's very dangerous. But that's the reason petroclivar meningioma is a completely different story. But in vestibular schwannomas, there is absolutely nothing within the tumor, only tumor. So you can go quickly if you enter the tumor, you can quickly with the CUSA, you can evacuate the tumor more and more and more and more. And then you get the border of the tumor with one hand, and you can dissect the structures with the other hand. Then you remove that part. and then you continue with CUSA, and then again you make your dissections. So you must pay attention to the veins which are displaced, usually between tumor and brainstem. I use as less bipolar as possible. I use a lot of irrigation, one of the causes of deterioration of the nerves is the use of bipolar, because you cannot control the heat, but you can control your movements, you know. So this is one of the advantages of the sitting position. You use very few bipolar coagulation. Yeah.
Thank you.
We do have large tumors because we receive many patients from abroad. In Germany, they are not very common, but we receive many patients from abroad. And the neurofibromatosis patients, they are sometimes very big tumors as well.
Thank you so much.
Thank you. Thank you very much, Professor. Is there any question from the panelists?
Yeah.
Yes, Dr. Chen.
I see you.
Yes. Thank you, Dr. Tatagiba. Yeah, this is very useful and fantastic presentation, and very good tips to our young neurosurgeon. And I love to watch your very beautiful surgery technique. And my question, one of my question is, do you have some recommendation to resection process when you resect the tumor from the center of the tumor or the side of the tumor begin to resection? The second question is, do you have any tips or experience how to protect the facial nerve? Someone said exposure before you start to resect the tumor. Someone told me you have to protect it. Don't touch the nerve before you start resection tumor. Thank you.
Look, if you are coming from the retrosigmoid approach, you will approach the tumor from behind, the dorsal part. In the large majority of the cases, there is nothing at the posterior border of the tumor. In very few cases, there is a paper showing that in about 0.6% of the cases, you may find the facial nerve running at the posterior side of the tumor. Okay, so if you have suspicion that this is the case, but it's an uncommon phenomenon, then you have to use the electrode to stimulate the posterior surface, and then you will detect the facial nerve. If the facial nerve is there, then you must approach from above or from below first, so you can do it. And then when the pressure is going less, then you can mobilize the fibers, okay? But this is uncommon situation. It's uncommon situation. We will find this situation in trigeminal schwannomas, for instance, that displace the facial nerve posteriorly. Then we have to do the same. But usually in vestibular schwannomas, there is nothing at the posterior border. So you can take your scissors and make a big hole on this tumor, because there is nothing inside. There is no vessel, no nerve, nothing inside the tumor. You can make a big hole with your scissors, then you put the CUSA, and quickly you can reduce the size. Of course, you must get feeling when you are coming too close to the anterior border. You will see that the surface starts to pulsate. When you have the pulsations, then you know you are coming close to the end, okay? So, and how to preserve the facial nerve. What we do is we enucleate the tumor, then I start at the inferior border, okay, inferior part, then I go to superior part, and once this is debulked, then I go to the brainstem. I take the tumor with one hand and I separate the arachnoid with the other hand, and then you will find the facial nerve at the brainstem. So it's almost the same. It's almost the same. These surgeries are very similar to each other. Okay.
Okay, thank you so much. I got it.
Yeah, I hope you could answer your question.
Okay, yeah, thank you.
Yeah.
Thank you very much, Dr. Chen. Is there any question from the panelists or from delegates?
Hello.
Yes, Dr. Pirzad,
Hello.
you want to ask any question?
Yes. Hallo. Guten Tag und Dankeschön, Professor Tata Geber. Sehr
Yes,
good presentation. Yeah,
I'm
Dankeschön.
not seeing you. Let's see.
Yes.
I cannot see you, but
Hello, hear me?
okay. I can
Yeah.
hear you. I cannot see you, but I can.
Yeah, this.
Yes, okay. And now I can see you. Your picture is here.
Yeah.
Hello.
Hallo. Dankeschön
Salam
for this presentation. I have two questions. One is what's your advice for those centers but low resources like Afghanistan that we haven't microscope or microsurgery, and what's your advice for macrosurgery? And the second, I like to know, is there possibility for training of our young neurosurgeon for some scholarship or fellowship in your center?
Okay.
Is it, yeah, is it Mughalish?
Yes. So I start with the second question. Yes, there are the fellowship programs of the World Federation. We train 4 people per year. It's a 3 months fellowship program, very successful. This year we had to stop because of the COVID situation, but I do hope next year we can continue with this program. You are, very welcome to introduce your people. It's of course important that they can speak or at least understand English, so they can communicate and understand. But they spend 3 months in our department. We have 1 fellowship for adult neurosurgery and 1 for pediatric. So at the homepage of the WFNS, you will find our institution. And if you can give your support, I will pay attention to that. Okay. And so if you don't have any resources, so you said no microscope, then
Yes.
There is a risk that you achieve the results that we know from pre-surgical era, from Walter Dandy and so on. So he produced good results for that area, for that time, but not for today. You cannot achieve the same results if you don't have microscope. So if you don't have microscope at all and you have a large tumor, then you must do a larger craniotomy. Maybe you must resect part of the cerebellum, and then you must debulk the tumor, and that's it. So otherwise the risk is too high that you produce problems with the lower cranial nerves, swallowing problems, facial palsy. These would not be good for the patient. So if you don't have any possibility to use microscope, then you have to do debulkings only. But there is a program of the World Federation together with Esculap that you may receive a cheap microscope. Yoko, I guess this program still exists or not? You are muted?
No. Yes, I hear you.
Yeah.
Yeah,
Yes,
that's
I
through
hear.
the Government's Foundation. I think they can receive
Yes.
a very primitive microscope, even though.
Yeah. I guess you do have chances, you know, because Afghanistan is very much focused today, and maybe you have a good chance.
Okay. Dankeschön.
Welcome.
Dankeschön.
Yeah.
Thank you. Thank you very much, Professor. I think we are having an excellent discussion, but we still have 2 more talks to go. So I think we will hold on for the discussion part. We'll take the next speaker and then we'll come back to the discussion, whatever, if anybody has any question. So allow me to introduce our next speaker. Our next speaker is Professor Tadashi Watanabe. He has done his MD from Nagoya University School of Medicine. After that, from 1996 to 2000, he was a resident in Department of Neurosurgery at Toyohashi Municipal Hospital. He finished his neurosurgery residency in 2002 from Nagoya University, and 2003 he became the board certified member from the Japan Neurosurgery. In 2011, became the associate chief at the Department of Neurosurgery at Nagoya Diani Red Cross Hospital. At the moment, since July 2019, he is the associate professor at the Department of Neurosurgery, Aichi Medical University. He has various awards. In 2003, he had received the Excellent Paper Award from the Chubu Division of Japan Neurosurgical Society. And 2019, he received the Best Operative Technique Award from the Congress of Neurological Surgeons. He has a deep interest in minimally invasive keyhole and endoscopic surgery. So today he is going to talk us about endoscopic keyhole approaches. Over to you, Professor Tadashi Watanabe.
Okay, thank you. Thank you, Dr. Sachin. I'm going to share my slide. Okay. Okay, can you see my slide?
Yes.
Yes, Prof. It is visible.
Okay, so, okay, I will start my lecture. Well, slideshow. Okay, so thank you for giving me an opportunity. And today I'm going to mention about actually combined endoscopic and exoscopic minimally invasive neurosurgery. Okay, so I'm Tadashi Watanabe from Nagoya, Japan, and I'm working on endoscopic neurosurgery for about 20 years. And I started this endoscopic keyhole approach since 2007. From small craniotomy with less brain retraction, we can get a wide surgical view by endoscope. So I started this approach with a simple case in the beginning, and gradually by the development of tools and the development of our surgical technique, gradually we shifted to complicated cases. So today I show you the cases, the recent cases we experienced. Okay, so these are the advantages and the drawbacks of endoscopic keyhole approach. Advantages are with a small entrance we can approach with a wide viewing angle, and brain retraction is less. And also we can do underwater surgery. We call it wet feed technique. And on the other hand, the drawbacks are the most big problem is a confliction of tools, the clash of tools and endoscope. And also there is a blind area at shallow part, the backside of the tip of endoscope, there is a blind area. And okay. But these problems are resolved by curved and flexible tools. And sometimes scopists will move a little bit and avoid the clash of tools. And at shallow part, we use the exoscope. Okay, and actually since 2019, 2 years ago, we have got a 3D exoscopic system, STOTS VTOM, and we started combined endoscopic and exoscopic approach. And actually, for almost all the scheduled cases, we use this technique for brain tumors. So in this approach, we can switch the viewpoint of the surgical field, and we can obtain an appropriate view. And the surgeon and the scopist proceed the surgery together. This is the 3D VTOM. We wear the 3D glasses and by the hand, using a hand controller, we can adjust the focus and the zoom. So what is the advantage of the exoscope? First of all, it is small, much smaller than when compared to the microscope. So it means good handling. And the second of all, it has a free visual axis like this picture. This visual axis is like almost a horizontal. So, and the surgeon is a normal posture. So this free visual axis provides us a comfortable posture for surgeons and even the patients. And the scope is controlled and adjust the position of the scope and adjust the focus and zoom. So it means a surgeon can concentrate on the surgery with the two hands anytime. And one of the most important thing is it is exchangeable to endoscope anytime. Because the two of these scopes has monitors, and we look at monitors. So we don't need to change any setup of OR. So we can change to endoscope anytime. That is one of the most important things. These are the curved and flexible tools we use. And this is the OR setup. And we put the monitors in front of, and we put the scope stand here, just in front of and put another scope here. And this is a Unium, the floor standing pneumatic holder, which hold the scope. And I show you the video of CP angle epidermal cyst with the trigeminal neuralgia. And the patient is placed in supine lateral position, and the head is rotated with the holder, and endoscope first, and we made a 2.5 centimeter small craniotomy, and the scopist is controlling the position of the scope. And from the dural cutting, the surgeon is look at the monitor. And now, first we drainage. We drainage the CSF from the cerebral medullary fissure. So in this part, the scopist is moving the scope, and the surgeon doesn't need to move the scope. So he can continue the two-hand surgery. And the one problem is white out, because it is a digital image. So sometimes in such we can control, so we can control the white out. So all those things is done by a scopist. The scopist will, control the images. Okay. So mostly this kind of tiny meticulous surgery is available with a 3D exoscope. So the surgeon is dissecting the tumor around the petrosal vein. Okay, so after, sorry. So after removing some amount of the tumor, so we change to the endoscope. And there's a much space here above the patient, so assistant can do the job because there's much space. So now the scopist is changing the scope to the endoscope. So we can quickly change the scope. Just change the scope, and the surgeon is standing here, and there's no need to change any position or setting, nothing. So, and the monitor is same. So we can continue the surgery. So so the endoscope, because we have to put the endoscope into the skull. So we have to watch out the movement of the endoscope, not to injure the structure. Okay, so now you can see that this tiny vessel is feeding the brain stem. So we have to preserve the. So now we are dissecting the vessels from the tumor capsule. So as you see, the viewing angle is much wider, so you can see the corner. And in irrigating water, you can see the images here. Okay. So the tools of surgeon and the endoscope is moving together. Okay, so we use the 30-degree endoscope. So now the endoscope is at the 6 o'clock. So surgeon is talking. Okay. So now in the wet film technique, there's no tumor left. So we finished the removal of the tumor. So then we change the exoscope again and we close the wound. Okay, so I show you another cases. This is an old man with a parasitical meningioma, but there's a diploid vein just on the tumor, and also the bridging vein here. So on approach, from frontal space, we observe the tumor, and with the endoscope, we can observe the tumor carefully. So after this section and the detachment of the tumor, we could remove the tumor very well. And this is the post-operative MRI. The tumor was resected from the anterior side. And this is the C1 meningioma. The tumor is at the ventral side of the brainstem. So with the hemilaminectomy, we could approach to the first we use the exoscope, and after removing the tumor as much as possible, then we change to the endoscope, and we look around the corner, the ventral side of the medulla, so that all the tumor is removed. This from this hemilaminectomy and a small wound. And this is the case of petroclivar meningioma, which is extending to above, up to the stern, exoscope. We remove the tumor as much as possible, and then by using an endoscope, we looked above, and also we could look around the corner around the Meckel cave. And now the picture is looking up. So you can see the PC and third nerve and fourth nerve. So it's gone. The cavernous sinus. Okay, this is a MVD. So recently we have started underwater surgery for MVD. After dissecting the arachnoid membrane of around the lower cranial nerve, once we reach to the surgery. So in this case, the responsible vessel is vertebral artery. So now we are dissecting and moving the VA in a wet field. So by using an endoscope, we can look the routine exit zone clearly. And we have done an interposition, then close the wound. In this case, mostly we use the underwater surgery. Okay, here is my conclusion. Using exoscope and endoscope, the viewpoint can be switched between outside and inside of the surgical field image. So here I show you the advantages of exoscope. It is small and it has a free visual access, and it is exchangeable to endoscope anytime. And but we have some disadvantages. Still, there it is insufficient image for highly magnified view and a deep and a narrow area. But it is resolved by the endoscope, which has the advantages of a wide viewing angle and with a small entrance and close-up observation, underwater observation. But the endoscope has a disadvantage, the clash of instruments. And it is resolved by ingenuity of tools and by the role of a scopist. These two things will resolve the clashing problem. Okay, thank you for your attention. Okay.
Thank you. Thank you very much, Professor. Is there any question from the panelists or delegates?
I've got a question, if it's possible.
Yes, Professor, please.
Yeah, thank you very much. It was a very beautiful lecture. I enjoyed a lot, and also you showed the advantage, limitations, and was very nice. I had, for instance, experience with exoscope in epidermoid, and
Yes.
my difficulty was either was the epidermoid too bright and
Yes,
everything else
exactly.
was dark. You know, I had a difficulty with the optic. How do you solve this difficulty?
Okay. Did you use the Stolz system?
Yes.
Beton? Yes.
Yeah.
By using a AEL button, you can fix the exposure, the light exposure. So if you feel white out, you can put the white gauze piece in front of the camera and put the AEL button. So the image will be a little bit darker, a little bit dark, but you can see the clear image on the white tissue. So, you can control the white out with a AEL button. I don't know what is the meaning AEL. Yeah,
okay. I will check that.
Maybe the stores person will tell you.
Yeah. Okay. Thank you.
The tips of control there.
Thank you. Thank you, Professor. Is there any other question from the panelist?
So, Dr. Watanabe, please, Jen, you first.
Okay. Yeah. Thank you so much.
Hi.
I have a question. Yeah. Thank you for your bit of a presentation. I have no questions, but I want to share some information with you. My senior neurosurgeon in Renji Hospital, Dr. Miao. Dr. Miao recommended the endoscope combined exposure surgery very much. He did much surgery, but he has no such beautiful equipment stores 3D. He only used common endoscope equipment combined with the normal scope. He told with me, discussed with me, if we can make the tumor cyst formation, that will make the surgery easy, because we only use the endoscope to absorb the cyst liquid. Then the residual tumor is easy to be resected under the endoscope. Interesting. Do you understand my meaning?
Sorry, I couldn't get you because of some network problem. So please tell me once more.
Yeah. My major research is about tumor cyst formation. To such cases, the surgery would be easy to resection. Cyst, cyst formation in the tumor. He think if we can make the tumor cyst formation, we just use the endoscope absorb draw out of the liquid. Then the residual tumor is easy to be removed. The system. If the tumor is big and tough to remove, cyst tumor. Some tumor only 7 to 8% tumor can be cyst formation. It's nature. It's nature. Yeah. So to such cases, it's easy to be removed. So just
using endoscope, going into the cyst is very hemangioblastoma. Okay. For example, hemangioblastoma with the cyst and the nodule, it is easy to go into the cyst and remove the nodule is much easier.
Yes, I think it's not only
and also for the tumor in the ventricle, so you can fill the water inside the ventricle and make the space, and you can observe clearly the tumor. So there's an advantage to approach to the ventricle tumor.
Yeah. So we are thinking
Okay.
if we can find some drugs or radiation, anything, treatment, we can make the tumor to be cyst formation or soft. It's easy to draw it off in the surgery. So we can easily to combine endoscope and expose endoscopy to resect the tumor. My senior neurosurgeon, Dr. Miao, he published a publication in Chinese, but it's Chinese. He researched many cases and analyzed. He think the combo surgery is better than the traditional stent surgery. Okay, just share some information.
Okay.
Yeah. Okay. Thank you so much.
Professor Miao says the cystic tumor is much more.
Yes, he think if when we observe the MI before surgery, there is a cyst in the tumor. What kind of tumor pathology? Such tumor is easy and good to do the combo surgery. Endoscope and exposure. Yeah, scope.
Okay.
Okay, thank you so much. Maybe next time I like to talk with you. You can discuss the combo surgery. Okay, thank you so much.
Okay, thank you.
Thank you. Thank you very much, Jane, for the active participation. Are there any other question from the panelists?
Dr. Prasad, please.
Yeah.
Dr. Prasad, you want to ask a question?
Yeah, thank you. Thank you very much, Professor Batnabi. That's as we know that the complete resection of epidermoid mass is sometimes is not possible. What is your advice for residual tumor, alternative treatment for residual of tumor?
Yes, for epidermoid cyst, the point is the removal of the membrane, which makes the content of the tumor is important. So we always watch out where is a responsible membrane. So it is always on the fifth nerve or eighth or seventh nerve. There is a membrane attaching on the brainstem. So we always try to remove them. Otherwise, you can just suck the tumor, like extending above and below. It is easy to suck the tumor mass. So in this case, in this kind of epidermal cyst, the endoscope is very useful when you remove the tumor, which is extending upper and lower. Yes. And
thank you.
I think one thing can I ask the Professor Pizad from Afghanistan? You said there is a hospital which there's no microscope. So how about the endoscope in such a hospital? Do you have a endoscope in such a local hospital or somewhere?
No, unfortunately, not in public hospital. We haven't microscope or endoscope, but
no endoscope.
In some private we have, yes, but not in public hospital.
But yeah,
yes.
I think
unfortunately.
You know, the exoscope is much cheaper than microscope, and also the 2D. There's a 2D exoscope from stores that is very much cheaper than microscope.
Okay.
So in such a situation, maybe you can get you know, microscope like scope. It's an exoscope. It may be you know, good for some kind of a local hospital.
Okay.
Because it is
thank you. Thank you.
Okay.
Thank you for your advice. Yeah. Yeah.
Yeah.
Thank you.
Thank you. Thank you, Professor. So is there any other question from the panelists?
Yes. The guy from left questions.
Yes. Thank you, Professor, for the for your beautiful talk. And I would like to ask, in trigeminal neuralgia, what is the material that you usually use to intervene between the vessel and the nerve?
You know, the Teflon cotton, Teflon.
Teflon.
Yeah, yeah. Nothing special. It's a Teflon.
So any technique that you make it very fixed between the vessel and the nerve, you use any material to stay in place, or you just put Teflon there?
Yeah, just put the Teflon and fix by a fibrin glue.
Fibrin glue. Oh, okay. Thank you so much.
We prefer interposition, and because we can by endoscope. And put Teflon there and fixed by a fibrin glue. Okay.
Thank you for the answer.
Thank you. Thank you very much. Any other question from the panelists? If there are no questions, then we'll go ahead with our last part of our webinar, that is a short case presentation on the similar topic what Professor Marcos Tatagiba was presenting. We have Dr. Heba, who is a young lady dynamic neurosurgeon from Egypt. She is working as an assistant lecturer at Cairo University and Children's Cancer Hospital, Egypt. With that short introduction, over to you, Dr. Heba. You can start your case presentation.
Hello, Sachin. Hello, Professor Katsu, and hello, all professors. Thank you, Professor Tatagiba, for this nice presentation. Thanks, all professors, for the presentation. I have a short case. I would like to start. So the screen is okay with everyone?
Yes, it's visible. Go ahead.
Yeah?
Yes,
you can see my screen?
Yeah,
great.
We can see him.
Great. Okay, so we'll be talking about a small presentation about NF2, and as we discussed in this webinar about the techniques and the surgical procedure and everything, maybe we can go a step before and consider the decision making in such case. I'm still in my final year in the residency, but I think this case might be interesting for all of us. So let's start. This is an NF2 case. He had a bilateral schwannoma. He's 25 years old male. He had a mental disability and learning difficulty. I think that was more contributed to that he had a hearing difficulties starting from a young age, but that wasn't actually quick diagnosed and was contributed to a mental retardation. He didn't have any family history of cancer or any oncological background. The presentation started that he had difficulty in walking, and he had an ataxic gait. He had a clonus. So, and he started, his mother started to notice that he had a progressive hearing loss. Also, he isn't very cooperative in the examination, but on the examination, we can say that he had a little low IQ. The cranial nerves we had on a geometric examination, a decreased hearing on the right side. He had partial bulbar palsy. The gait was wide-based and was ataxic. He had the right hemiparesis grade 4. It could be contributed also to the spasticity because he was a little bit spastic. Maybe it could be more weak. He had all the positive cerebellar reflexes and extrapyramidal reflexes. On the skin, he had the patches, café au lait patches. That all goes with the NF2 diagnosis. The audiometric, he had a hearing loss more on the right side. On the fundus, he had a papilledema grade 2. And that was the image of the MRI. He had a 2 bilateral CP angle lesion. And that wasn't the case only. He also had a cervical lesion around C2 and C3. So we started having a dilemma in which and where should we propose our next step. Also, if you can see that in the MRI, the ventricles are a little bit dilated. And with the fundus, he had a papilledema grade 2. So we didn't know which step should be the first step, because if we thought shunting, then we were very afraid of the upward herniation. And if we thought the cervical lesion, we were afraid of the brainstem manifestation, or maybe an infarction or something after the procedure. So we started with the CP angle lesion. We had the right retrosigmoid approach for the debulking of the lesion. We had a neurophysiological monitoring for the facial nerve. And that's the CT post-operative. We didn't have quite time to do the MRI. Then the patient started to manifest with clonus. He had the spasticity was more prominent and was more severe. His conscious level started to deteriorate. So we proceeded with a VP shunt. And that was the CT post-operative. At the same time, we had a tracheostomy for the patient because he had a bulbar palsy and he was intubated. So instead of staying on that tube for a longer time, we thought tracheostomy would be a very valid point. So to avoid any more further injuries for the vocal cords and the esophagus. But later on, the third step was to do the cervical lesion, but unfortunately the tracheostomy was slept, and he had a blockage in the tracheostomy, and he died of this cause, unfortunately. So this is quite a quick review on the case, but the question remains in similar cases: what should be the perfect surgical sequences for this case? Should we proceed with the CSF diversion, or should we proceed with the cervical one, or should we proceed with the cranial? Putting in mind that doing the cervical and the cranial in one procedure would be a very lengthy and would require a multiple position and changing of the position, which isn't very useful. And then after choosing the cervical surgical sequences of this case, is any role for the adjuvant therapy in this case? Should we keep him on adjuvant therapy or not? Putting in mind that he has two CP angle lesion and there's a smaller one on the left side that we consider to leave it as a first management of the step. So those are all the questions that we have, and I thought we could discuss it all for further cases with NF2. And at last, I just want to send our wishes and prayers to all people in Afghanistan, and we wish to stand in solidarity with you and to help in any possible thing. And good luck for all the neurosurgeon and all the people there. And please, Dr. Sachin, if you would like to moderate and facilitate the conversation, if someone has topics to discuss about this or questions, where to start the surgery. So please,
Sure.
I'd love to hear.
Thank you. Thank you very much, Dr. Heba, for that excellent case presentation. I'm very, very glad that you got this topic for the discussion today. I think the skull-based surgery, NF2, is one of the most debatable topics. And without losing any time, I think we'll go straight ahead with Professor Marcos Tatagiba. There's nobody other than him who's the expert at the moment to give us advice about this. So, Professor Tatagiba, what should be the first surgery, whether to shunt or not to shunt? One thing, when you're attacking, which is the lesion to attack first? Is it the cervical or the CP angle? So these are the two topics for the debate today. Could you please advise us on that topic, please?
Thank you very much. First of all, I would like to congratulate Dr. Heba for the nice presentation. Shukran.
Thanks.
Shukran.
Thanks, Dr. Tatagiba.
And so we have a comprehensive neurofibromatosis center here in our institution with more than 600 NF2 patients being under treatment, and many from other countries, including some patients from Egypt as well, by the way. And for me, it was not very clear whether this cervical tumor was intramedullary or it was intradural extramedullary. Was it an ependymoma or a schwannoma? It was not clear because the pictures didn't come very nicely.
Yeah, I could show it to you, but it was for sure intradural. It has a part in the foramen, So we thought it would be
Schwannoma.
neurofibroma or schwannoma, but
yeah, okay,
didn't
not a
proceed to know
neurofibroma.
exactly.
Okay, not a neurofibroma. This is a schwannoma because it's NF2. Look, this is very interesting that you said the patient had low IQ. NF2 patients have usually high IQ. This is interesting. NF1 patients have low IQ, but NF2 patients have the tendency to be more intelligent than average. This is very interesting because we have many patients concluding university, being professors with NF2. So if this patient had low IQ, probably this was because of the hydrocephalus, okay? And because the hydrocephalus was, in my opinion, symptomatic. It was not asymptomatic. And the second point is, because of the fact that this patient will be bilaterally deaf and under the hydrocephalus, this patient may become blind, which would be terrible for this person. So if this case was in our institution, our first step would be VP shunt before anything else. First, to give this lady the opportunity to save the vision and to increase the cognitive function. This would be the first step. I'm not saying that your management was not correct. Absolutely not. But I'm saying what would be ours. Okay. So the first step would be VP shunt. Then we would wait probably 2 weeks until brain is relaxed, everything is fine, no infection due to VP shunt, nothing, everything is fine. Then, because the tumor is very large and surely the lower cranial nerves are affected, we would do the large size as you have done, but we would do previously at the same step tracheostoma. It's a preventive measurement. You know, it's a difference. If you do this before your big surgery, this is part of the surgery. But if you do this later on, the relatives believe this is a complication. So I recommend you, when you have these cases, please put the tracheostoma first. It will save the life of the patient. Later on, you can remove it. It's not a part. And it's easier to explain to the relatives that this is part of the whole treatment, okay? So I would do tracheostoma, remove that tumor, because the patient has the shunt, is protected here, then the patient would recover, which would be the next step. The next step would be the cervical tumor, okay? And then is the decision, what to do with the other tumor. You have two options. You could put this patient under a bevacizumab trial, so chemotherapy. This is, of course, expensive. You must make oncological care and so on. If you have this infrastructure, if you have this support, you can offer this to the patient. Otherwise, you can go for a second surgery to the other side, you know. So bevacizumab has the advantage that you preserve hearing over a longer period if it works well, okay, of the size of the smaller tumor. But the other option would be to remove that tumor and put auditory brainstem implant. It must be discussed, but this is something that it can be discussed as well.
Can I ask a question, please?
Yeah.
Yeah, so while proceeding with the VP shunt as a first step, aren't you afraid of upward herniation, or aren't you afraid of more compression on the brainstem?
It doesn't. This doesn't happen. So this is, you know, people talk about this, is very unlikely to happen. You must avoid to put too low pressure. Okay, you should not put too low pressure, and it doesn't happen in adults. In children, it may happen. but in adults, it's very uncommon.
Thank you very much.
But of course, don't put the pressure too low, of course. Yeah.
Yes. Thanks a lot.
Welcome.
Thank you very much, Professor. Maybe putting a programmable shunt would help, or you just use a moderate pressure or high pressure.
What's the question to me? Or?
Yeah, but it's open question. Would putting a programmable shunt is a better option to choose a shunt, or we can use a medium pressure or a high pressure shunt? What do you think?
We use programmable.
Okay.
But they are more expensive and not everywhere available, in each place available. So if it's not available, and then you must use at least medium pressure shunt, not a low pressure. These would be dangerous.
Sure. Thank you, Professor. Any other doubt or any question anybody has? Or anybody?
It's a very challenging case, difficult case. So in future, if you have these, you can consult us. Okay, so we are open.
We sure do.
Okay. Sure. Thank you very much, Professor. Dr. Sharon. Dr. Sharon is president of Women in Neurosurgery. She's there quietly listening to everything. What is your experience about NF2, Dr. Sharon? Do you shunt first or you?
Yeah, I think it's like what Professor Tatagiba said. I mean, in our center, we do shunt our patients. Of course, cost is an issue. So ours is all moderate pressure. One of the reasons being sometimes the OT time, we don't have enough OT time. So we tend to shunt our patients first. And then like what he said, we usually wait about 2 weeks to a month, and then we proceed with surgery. NF2, I think, yeah, that one, it depends. Like what Hiba presented. Most of the time, if they present with bilateral, we usually excise the larger one. And then sometimes the smaller component on the opposite side, we follow up, or if possible, sometimes for SRS, depending, because, you know, patients going through surgery and the trauma of surgery, sometimes they are not very keen on a second surgery. Usually that's how we go about it. But we do have, then these patients become your lifelong patients, basically, Iba. They will be with you forever.
Yeah.
You develop.
One question. May I make one question? Which is your experience with radiosurgery in NF2 cases? Because particularly we try to avoid it. The results in our experiences are not so good, and we are afraid of malignancy in these cases.
So in my center, we do not have radiosurgery. So most of the time we need to refer to other centers. And so basically, like what Prof. Tatagiba said, they don't really get, we don't really send them for radiosurgery actually, because we don't have a center that can really offer us. So most of the time we follow them up. And if the size increases, then we tend to do surgery. So we don't really have proper experience on SRS, Prof, actually.
Okay. But a good option, if it's available, is try bevacizumab in these patients.
Okay. Oh, it's a good option, is it?
Yeah, in 1/3 of the cases, you may have shrinkage of the tumor. In 1/3, approximately, it becomes stable. In 1/3, it continues to grow. So, but at least you give the patient some time and option instead of surgery, and so you can preserve hearing for a longer period. Yeah, it's expensive and it needs oncological follow-up. Yeah.
Yes.
Thank you very much. Is Dr. Tadashi Watanabe is there? I'm just wondering if any experience of endoscopic or exoscopic surgery in NF2. Is he still there? Can't see him. Okay. Okay, then any other question from the panelist? Dr.
Hello,
Chen,
it's me.
you have any question?
Yeah, thank you, Hiba. Thank you to share this interesting case. And I have some idea. How do you know it's NF2 mutation? Do we have any pathology genetic mutation detected? You haven't the operation. Hi.
No, it was mostly diagnosed with the presence of bilateral sepia angle lesion and the skin patches and also a cervical schwannoma. So the clinical presentation was our guide. We don't have a genetic counseling. It's a very bit rare and very expensive. So we just use it in a very limited options.
Okay, I don't know. NF1 mutation, we have drug inhibitor that's you can try MEK inhibitor named as trametinib. If you can try trametinib combined with beva. And NF2 mutation inhibitor, the drug is very new. The name is TEAD, anti-TEAD inhibitor. I think there is some clinical trial in the world of the world. Maybe you can try reach some professor or research on the clinical trial. Usually in America, some drug company pharmacy is producing such inhibitor. Maybe you can try after or before surgery. Because the surgery is tough and high risk. So usually we love to combine neuro-oncology and oncology therapy after surgery, use some inhibitor, and the inhibitor can control the disease processing or
progression.
Yeah. So sometimes the tumor will decrease, the size will decrease when you use the new drug. Just my opinion.
Thank you. I'll check it.
Yeah, you can check. Thank you.
Thank you.
Thank you very much. Just a point to mention from the point of view of a young neurosurgeon. So whenever you have a tracheostomy and you're going to operate on the upper cervical, make sure your tracheostomy is fixed very nicely there with that nice big 10 echelon or 10 white rail or something. Give a 4 stitches tight there. It's going to have a lot of weight because of all those anesthesia tube, and it may come out. So I had that experience before. Thankfully, we were able to put back again. But sometimes small things are very important to have a successful surgery. So I think that was a take-home message for today also.
Thanks.
Okay. Any other question from the panelists? Dr. Liu, you want to say something?
No, Sachin.
Okay. Any other question? Dr. Hemanta is there from Sri Lanka. Dr. Hemanta. I think it's quietly listening to us. Okay, then. Yes, Dr. Hemanta. You have any question? Your experience on NF2?
Yes, thank you very much for that excellent presentations, Professor Marcos and the other professor, and for the excellent presentation regarding neurofibromatosis. We also have seen a lot of few cases regarding neurofibromatosis with bilateral sepia angle tumors. Recently, also last month, we did a person who was having a bilateral sepia angle tumor. That was a very large tumor, and initially we have done a VP shunt and then proceeded with the surgery after tracheostomy also for that patient, because on presentation he was having difficulty in swallowing and difficulty in a lot of complications he presented. Still patient is in our ICU. So we have seen this type of cases. And other thing is actually our centers are not that much high volume centers for CP angles. We are doing for over last 6 months, we may have done 3 or 4 cases CP angles, but we are doing those. So that's our experience. So these presentations are very helpful for us to improve. Thank you very much.
Thank you. Thank you very much, Dr. Hemanta. Is there any question from the panelist? Okay, if there are no questions, then I will just have a concluding remark as a moderator. And after that, Dr. Pirzat is going to have a 5-minute presentation about the status of neurosurgery in Afghanistan. So we had a wonderful webinar today. Thank you, Professor Marcos Tatagiba, for those tips and tricks for us, for the young neurosurgeons in retrosigmoid vestibular schwannoma surgery, and Dr. Heba for presenting a wonderful case about the NF2, and we could interact with Dr. Marcos on the similar topic about the challenges and complications of managing the case of neurofibromatosis. And Dr. Tadashi Watanabe for explaining us about the different techniques of using exoscope and endoscope in neurosurgery, and even the cost effectiveness of exoscope and endoscope in the neurosurgery. I think we have Dr. Watanabe back. I just wanted to ask a question to Professor Tadashi. Any experience of using exoscope or endoscope in neurofibroma 2 cases, Professor?
Yes, actually, I have experience of exo and endo surgery for vestibular schwannoma, but actually, not yet actually. But I have experience of multiple Faucin meningioma for NF2, multiple meningiomas. In such a case, from small craniotomy, we can remove the tumor along with Faux using an endoscope. So that was a very good, indication for endoscopic surgery.
Okay, thank you. Because what we have observed is generally the tumors of NF2 are relatively more vascular as compared to the routine non-syndromic tumors. So I thought putting an endoscope or exoscope would be a little more challenging because of the bleeding.
Okay.
Thank you, Professor. Dr. Pirzat, over to you. You want to say something?
Sachin, hello.
Yes,
Sachin.
Yes.
Yeah.
I think brain lab people are also there. Maybe Dr. Pirzat can speak for 5 minutes, and after that, we'll have a last 5 minutes talk from brain lab. Then we'll wind it up. So another 10 minutes only. Yes, over to you, Dr. Pirzat.
Yes. Thank you very much. Bismillahirrahmanirrahim. I'd like to present a short report of neurosurgery in Afghanistan. And this is Afghanistan Neurosurgical Society members. I'd like to have an outline about the donation of instruments, capacity building, and infrastructure. About the short introduction, still we have neurotrauma cases. As we mentioned before, we have a lot of neurotrauma cases, war wounded and non-war wounded, especially that's the war actually ended, but that's the celebrating gun firing and some war in some provinces. Also, we have a lot of trauma cases. Also, we have another trauma cases like hanging. We have a lot of hanging in cases hanging near women, and we still have a lot of neurotrauma cases, but we also have another cases of brain tumors, keys, tuberculosis, also spine trauma, and also discs. We have a lot of another cases as well. Other things I like to mention about the donation of basic neurosurgical kits. We like to thanks for WFNS Foundation, Afghan American Community, ACNS, Pakistan Society of Neurosurgery. Also, I like to mention and say thanks for Japan Neurosurgical Society. They donate generously previous leave for Afghanistan, basic neurosurgical kits that still we use it. Thank you, arigato. And in this donation, we have these basic neurosurgical kits for 10 public hospitals. As you know, we have 34 provinces, more than 35 million people, and only 150 neurosurgeons, and about 8 of them are women. In this donation, we have cranial sets, spinal sets, adult shunt passer, and child shunt passer. As Professor Kato promised, that we still waiting for 2 high-speed drills. That's donation of Professor Kato and ACNS, but you know that the border are closed, and also no air transportation is still to Afghanistan. For this reason, the high-speed drill is on the way. We hope that the borders and air transportation open, and we find them. That 10 seats that's donated, 6 of them delivered to capital and provinces, and 4 still on the delivering. This the Pakistani company who delivered the WFNS Foundation, Pakistan and Neurosurgical Society, and Afghan American community donation of instruments to Aliabad Hospital. This Aliabad Hospital Vice President and Administrator, this is the company guy, and this is Afghanistan Neurosurgical Society members, also young neurosurgeons, and you, as you know, we see the Dr. Rehana Ghaffari as well. This the donation of the company. We say thanks, and this is the seeds, and we prepare a appreciation letter for the WFNS Foundation and the Afghan American community, and also the Pakistan Neurosurgical Society. This appreciation letter, we also say thanks for them. And other things, this instruments, but the instruments not enough, you know. We need for infrastructure and capacity building. For infrastructure, we need a neuroscience institute in Afghanistan. That's in this Afghanistan Neuroscience Institute, we must use advanced neurosurgery, especially training for neurosurgeons, young neurosurgeons from the provinces. We need also research in Afghanistan in neuroscience. We haven't advanced diagnostic equipment in our public hospitals. And unfortunately, neuro-oncology also is another challenge for Afghanistan. We, as I mentioned in our before presentations, we had before radiotherapy and for brain tumors and spinal cord tumors. Unfortunately, we lost everything, and we haven't radiotherapy and radiosurgery nowadays in Afghanistan. We must send them, our patients, to abroad, but in recent days, it's impossible. And chemotherapy also another challenge for Afghanistan people. You know, this is expensive, and also there's the good quality medicine is not available in market in Afghanistan. For capacity building, we like to have short-term training programs as ACNS promised. That's, and also Dr. Sachin moderate that's the for 2 young neurosurgeons, 1 neuroanesthesiologist and 1 ICU nurse in India. But unfortunately, and upcoming events in Afghanistan, it's stopped, and I hope that Dr. Sachin will follow this, and we send our 4 young doctors for training to India, and we like to also have long-term training. It's very important. We like to draw your attention about long-term training programs like fellowship and scholarships. This is very important, that conferences and webinars are very important. Our young neurosurgeons, our senior neurosurgeons, also our students, they use it. But you know that we have the internet problems, but we download it from the net and show our residents in, during our conferences. Also, we like to have textbooks, CDs, films, as Professor Kato also agree with me for education material. Other things, we like to start a telemedicine program for complicated cases, as Professor Tatageba mentions, and you agree that for complicated cases and for our poor people that they can't going to abroad, we like to have the expert options and advice for through telemedicine. And we like to have QT for our young neurosurgeons. Thanks a lot. Arigato gozaimasa. Dankeschön. Shukriya, shukran, tashakkur. I also say thanks for Dr. Heba for her nice wishes about Afghanistan. Shukran. Thank you very much.
Thank you. Thank you very much, Professor Pirzad. I want to say we are actually happy for the progress you've done, for the help you've got, and the efforts we are doing in the education and learning to educate more neurosurgeons from Afghanistan. About the trainees in India, I am following it very closely because of the closure of the border issue. We're not able to process their visas from our international department. Once I get an approval from that, I'll definitely follow it up. And as long as the ACNS is concerned, we are committed for education and training. So we'll definitely follow that. Professor Yoko Kato, you want to say something?
Yes, yes. Dr. Prasad, thank you very much for your nice presentation about the donation or your situation in Afghanistan now. So you mentioned about the 2 high-speed rail. Maybe we can already I discussed with Teresa, the Secretary of the WFNS, but still some maybe some transportation, some the issue, I think. So maybe again, Dr. Tariq, he can support your donation, I think. So you can wait a while.
Yes, yes.
Thank you.
Thank you very much. Arigato.
Arigato. And today, I think it's very nice webinar again.
Yes,
so,
thank you. Yes.
Yeah, thank you, Sachin, for organization. And what about company presentation?
Okay, so now at the end, I am very glad to invite Mr. Jaya and Mr. Tung from Brain Lab, and I'm very sorry to keep you waiting for all this time. I just wanted you to have an idea of what we are doing and how you can help us or contribute in bridging this interaction between our faculties and young neurosurgeons. So this is a platform where we're trying to bridge the young neurosurgeon. We're trying to learn it from our distinguished faculties like Professor Marcos and Professor Watanabe was there today. And there was one exemplary case which was presented by Dr. Pema. So we wanted to, sort of improve this platform of case presentation and discussion. So can you just have a small 5 minutes presentation, what you are going to do and how you're going to contribute? Thank you. Over to you, Mr. Tung.
Yes, thank you, Dr. Sachin. I would also like to extend my gratitude towards Mr. Liu for actually introducing Brain Lab to ACNS to present this Quentry platform. So we certainly hope that the Quentry will be able to contribute to your meetings in the future. Okay, so I will start my presentation now. Let me enlarge my screen. Okay, so what I'm going to do is actually Quentry. So Quentry is basically a cloud-based data sharing platform from BrainLab. Okay, then these are the things that we can do. Basically, Quentry will be able to provide a secure image and document sharing platform through the cloud. So as it is through internet, so this platform can be accessed anywhere as long as you have internet data connectivity or any smart device or just a workstation. Okay. So in this platform, everyone will be able to view all the patient imaging and documents in one place, okay, which is placed in the cloud. Okay. And in combination with the Brain Lab planning software, for example, like Image Fusion, where you can fuse CT and MRI, for example, or you can also highlight some region of interest or some tumor. So if it is combined with the we call it element planning software, you will have a powerful planning application as well. Okay, so naturally all this data, whether it's planned or unplanned, can be accessed throughout any devices connected to the internet, and more importantly, can be accessed from different locations around the world. Okay, an example in the usage of Quentry is that a physician actually sees a patient in a private practice, for example. All the data, patient data, are stored in radiology, and radiology can actually use Quentry in order to transfer the patient data to another hospital. So this is an example of an improved referral communication, because Quentry helps to improve clinical response time, because the data can be shared almost immediately through Quentry. And it definitely eliminates CD handling, because normally the patient will actually get a CD from the first hospital radiology and bring it to the next hospital for referral. And of course, if it is transferred through the cloud, then immediate viewing is accessible to the referral hospital. And there's also a commenting function within the Quentry platform, where the surgeons can put in their comments so that the next doctor or physician can actually easily look at the comments and decide what to do next. Second case in use is actually a clinical specialist collaboration. For example, a physician can actually do some tumor contouring, and a physicist can actually plan on the dose planning later on. And all this plan and contouring can be transferred through Quentry, and cloud-based review and plan comparison can be done between different several physicians through the Quentry platform. Last but not least, orthopedic surgeon in various facilities. It doesn't have to be orthopedic. It can be actually any specialty. Orthopedic is just an example that is put inside this presentation. Okay, the surgeon assesses a patient in private practice, and all these are stored in radiology as usual. And this data can then be transferred to a planning platform. Okay, for example, for radiosurgery maybe. And once this is actually planned, the plan can be transferred to the surgery in the OR, or it can be actually transferred further for further discussion among the surgeons. So in summary, Quentry actually is able to actually instantly delivers high quality information. All the information or all the patient data and DICOM data can be transferred almost instantly through the internet. And it actually assists in creating referral networks, because since it's actually stored in the cloud, the referral network can be anywhere in the world, actually, not just in the same country. Okay, and you only need a single platform, which is a Quentry, for all these medical data image to be exchanged. Okay, Quentry also provide a single view of all patient imaging in one secure location. it connects all the imaging department and the patient documents to one central location actually. Okay, so it is everything is accessible online. As such, it actually supports very rapid collaboration between different surgeons and different clinical specialties or even different hospitals. Okay. And as I mentioned earlier, there are commenting functions which allows quick and easy feedback amongst the surgeons. And to put it further, the surgeon can actually use this Quentry platform in conjunction with a virtual meeting platform, for example, Zoom, like what we're doing here, or Teams, for example, to have a live discussion among a few surgeons. So that has been done in some centers actually, locally in Malaysia as well. Okay. So the Quentry actually supports multiple modalities, almost all DICOM modalities, MRCT, PET, echo. It also have advanced viewing control like MPR or CINI. And on top of that, you can also do some measuring functions, like for example, the size of the tumor or even the volume of the tumor, because within Quentry, there is a function to generate a 3D view. And from this 3D image, measurement functions such as volume can be produced. Okay. And of course, you can also compare multiple series and studies for the same patient. And if it is combined with other pre-planning software, like for example, a pre-segmentation software, so this segmented software will be visible in the Quentry as well. So then all these images or data can be transferred to BrainLab system, but I think for your application, it is actually more applicable to actually have a discussion panel between surgeons from anywhere around the world. And so we understand that nowadays data protection is one of the key function or key requirement of any patient transfer platform. So as such, we have actually done everything possible to keep it a very secure platform. So the platform is naturally password protected, is compliant with the HIPAA and high-tech requirements. It also has a secure encrypted connections. Okay? So the users are even able to de-identification, meaning you can actually anonymize the patient if you do want to show the patient name. All this can be set in the Quentry platform itself. And user activity log is also available in case auditing is required. So Quentry is actually free for use for individual account. So for the individual account, it actually consists of a 5 gigabit cloud storage. So of course, if it exceeds that storage, it will actually delete the previous data. And there is also a sharing function between the surgeons. Whoever is in the contact list of your Quentry platform, you can share the information with them securely. So because of course there's a HIPAA compliant as I mentioned just now, and also grade A rating from Intel McAfee in terms of security, including SSL encryption. So you can actually register for free to try Quentry out at this link here. So before I end the presentation, I would like to pass the presentation to Asli, my colleague Asli. Will be showing a short demo on how Quentry is can be used. Okay, Asli, I hand it over to you.
Hello, thank you, Mr. Tang. Thank you, Sachin, Dr. Sachin, and distinguished panels. Let me share my video here. So as you can see here, you can access Quentry from brainlab.com. And then from here, you can go to Quentry Cloud Services. So as Mr. Tang mentioned just now, basically you can sign up for free here, and it will forward to the registration. And after you fill in all the details, you will get an email for activation. Let me show how to log in. So here, basically, you log in with the BrainLab ID that you created during registration. Once you enter, so then you will see the main user interface of the Quintry. So as you can see on the left side, there's a side menu here. What you want to do for the first start, basically you can upload the patient data. So from here, you can add a folder or add a files. And the file can be either DICOM, image data, even PDF. So for example, I will upload one type of data here. So once you have put up for the upload, you have to proceed here and then check for the patient consent and create a new folder. You can also upload to your own storage, or even you can have like a care team, which for example, if you have a hospital or hospital team, or you can also assign to your department. Yeah. So for this one, I will put here, upload. Okay, here I just put a small sample to upload, and then you will see there will be a message file uploaded successful. Then the next, you want to see the patient that you'll be uploading. Then from here, you can see the my patient and this data which just uploaded. Once you have the data uploaded, you can also view that particular data. And this patient data will be forwarded to a DICOM viewer, which is quite powerful, where we have like viewer here that you can view in the actual coronal sagittal view. And also you can create a 3D view from the data uploaded. So this for example of the view. And you can also do like a multiple view of images. See here. Okay. Go back view again. Sorry. Okay, let me show the 3D view again. Okay, then you can optimize the view for cranium, for example. And here, example of the 3D created based on the image that you already uploaded and the object already created. So from here, as Mr. Tan mentioned, you can also do some measurement here. Yeah, for diameter and also other type of measurement. And basically you can also zoom in and scroll the image. Okay, then I will proceed for the next function that we can do in Quintry. As Mr. Tan mentioned, any surgeon who already viewed can put a comment. And it will be logged into the patient folder. Okay. Other than that, you can also manage contacts with which care teams that you are sharing and with any individual contact. Yeah. And again, this country is, as you know, is for the patient data uploading and archiving. And eventually you will need for the live discussion using a normal, what we call the virtual meeting platform. Yeah. I will hand it over back to our host, Dr. Sachin. Yeah. Thank you.
Thank you. Thank you very much, Mr. Azli, Mr. Tung, and Mr. Jaya. So, is it okay if I stop your screen?
Yeah,
share?
Sure.
Sure. Okay. Yeah. So, thank you very much for that excellent presentation. So, I was wondering, so Dr. Liu, how we can actually, how can Brain Lab help the YNS committee or the whole concept? How is it useful? How we can go ahead with this?
Yeah, thanks, Sachin. Actually, thanks to Mr. Jaya, who is our regional director for sales of Brain Lab. And I'm one of the users of this country. And based on our earlier webinar session, we think there are many good cases to be discussed with our expert. We have many experts willing to join us, like Professor Marcos. I think their experience in helping us very vital and important. And what we can use with this platform is we can create a group of experts in various fields. And the usual we come from young neurosurgeons in our platform. So we have Brain Lab to assist us in technical issue. They're just showing some introduction how we can use it. It's an encrypt system, so you don't need to worry about outsider can get hold into your material. But more importantly, they have a platform to have putting in notes and discussion point, so you can do it at your leisure time. For example, let's say I have some CP angle tumor. I would like to have Professor Marcos to give me an input on what's the best approach, which one I should tackle first. For example, I can upload all the images, important images, and Professor Marcos can take his own time to help us to study and put in his comment. I think this is very valuable, and we cannot do it all the time on the Zoom session, some of the discussion, because like, for example, Dr. Heba have shown some images. Probably she's unable to do all the images in one go in her PowerPoint presentation, where she can actually share the images earlier before even our webinar session. So those experts can have a look at the images and come on live to give their live comment, and they may even reply in more details using this system. And what importantly, this system is free. So everyone can have their own account for free and do not have any financial liability or burden to any one of us. And more importantly, the Brain Lab are here. They're willing to assist us if we're going to face in any technical problem. For example, uploading images, what type of images we can have, and probably in some technical issue. So I thank Dr. Jaya for agree to assist ACNS, and we find that we really need some free platform, especially for our young generation, where we need such support. Probably I may get some opinion from Professor Joko Kato and probably Professor Marcos, that if you have any opinion that how we can make use of this platform. Thank you.
I've got a question on that. How much hardware do we need for that? Or is just a software issue. For instance, to receive the image and to give some advices, recommendations.
So, Mr. Jaya or Azli, do we need any extra hardware or just the software you can use in your computer or a mobile app?
Yeah, may I answer the question? Yeah.
Yeah, Azli, carry on, Azli.
Yeah, the requirement is actually quite low. Basically, you need access to the web browser. If I can show you quickly, whenever you're able to access the country, you can have this what we call a manual. And then there's a requirement here, quarantine technical, just to be very specific. Yeah, you need at least a Windows 10 and web browser, yeah. Chrome 85, and this is the requirement, yeah. So the RAM also is not that high, 2 GB only.
Okay.
Yeah, I think just to summarize, simple computer can do the job actually, you know, because all the what calculation is being done in the server, in the cloud server actually.
Yes.
So I'm not sure if we answered your question, Prof. Yeah.
Yes. Yes. So it's actually a software issue, huh? And how would be the procedure? So would you make it available for the colleagues in some specific countries, and then in some specific centers here, or would be your procedure?
Oh, I think the free software is, you know, it is anyone can actually access it actually, you know. So that means
everyone can access. Okay.
Yes, exactly. There's no limit for any countries or any what departments also actually.
Yes, I think this is a good thing. One method I could imagine is to establish 1 day a week. We could check some pictures and give advices. Of course, we must limit the number because we cannot, of course, analyze too many cases. Yeah, but I can imagine that the most complex cases could be analyzed and discussed. And then it's up to the patient. If the patient wants to have a direct contact, just to receive direct information, we can make an arrangement, virtual arrangement. So this platform is only to exchange pictures, right? It would not replace some, I would say, program like Skype or something like that. Is that correct?
Yes, so, you are exactly right, Prof. Yeah, correct. That means we usually use the Teams, Microsoft Teams, or it can be also in any other communication platform actually. Yeah.
Ah, okay. Okay.
Azli, feel free to add if you have any other.
Yeah, it's correct. Yeah.
Okay.
Thank you very much, Azli. I think it's an interesting platform, and with the increasing technology, I think we can give it a try, and maybe it can be done as a pilot project. What I think for the ACNS YNS, we can have all our YNS member there registered, and we can start putting up the cases. We'll decide on certain expert faculties like Professor Marcos who's agreed to review it once in a week, which is actually possible and more logistic thing. We can't keep on checking it every day. So maybe on weekend you can have a review of whatever cases you put there and whatever the expert coming. So I think we can be done as a ACNS YNS pilot project, I think. What do you think, Dr. Liu?
Yes, Sachin. That's what our aim actually, to get more help to our young people and with the experts around the world.
Sure. So at least maybe what all the faculties we had for our webinar, ACNS YNS webinar, all those faculties and all the ACNS YNS member, we can put together as an expert group and as a YNS group, and we can start putting up the cases, and we can review it maybe after 1 month or 2 months, how much effective it was, and then we'll see how it goes.
Yeah, it's a good idea.
Sure. Thank you, Mr. Jaya, Mr. Tung, and Hazli.
Thanks, Dr. Wat Sachin. And then I just, allow me to thank, what do you call, Dr. Liu, and then Prof. Yoko Kato, from Prof. Tata Giba, and also I see Dr. Sharon here actually. Okay, so maybe we have countries there. Okay, thank you very much.
Thanks so much.
So thank you very much. With that, we have come to the end of today's webinar. We had an interesting webinar, excellent lectures, excellent case presentation. I think it was a very interactive question and answer session today, because the topic itself was very debatable topic. And then the report by Professor Pirzad about the status of neurosurgery in Afghanistan. I'm very, very happy for that personally. I think whatever efforts we are taking for the education and learning, I think they are getting materialized. And at the end, Mr. Jaya for telling us about this wonderful platform. With that, I would like to end this. Before that, I would ask Professor Marcos to give us some encouraging comments at the end for the people of Afghanistan, Myanmar, and all the young neurosurgeons around the world.
Yeah, first of all, I must say that I'm very impressed by the quality of this webinar. Very good organized, excellent, really excellent organized, and I'm very impressed for the whole organization. You could put industry, experienced neurosurgeon, young people, everybody together. And this is, I guess, it's a model for other kinds of webinars. And for me, it was a great pleasure to participate. You know, today is Sunday. We started, I was here at 11 till 3:30, and family called several times for lunch. But for me, this is my lunch, to stay with you here and to exchange. It was very nice experience. Look, I have no words to say to express my feeling to the colleagues living in conflict areas. So the report of Dr. Pirzad was so impressive. Yeah, I was really touched when you said that one of the big issues are neurotrauma, hanging trauma, and very frequently in women. So this is really a heartbreaking information for us. And I'm very disappointed to get knowing that so much money has been spent in your country for other purposes, you know, and I'm not going to be too political here. And if I see the condition of the hospitals you are working, it's really so disappointed for the world community. It's very sad. It's very sad that human being is like this. And I do hope that we all have the opportunity to give to you and to people in other conflict areas the full support you deserve in order to do the neurosurgery you are capable to do. Yeah, and from my point of view, so what I can do, I will try to do, and I will make some announcements in our societies, and I hope we can come back in future with some offers. And so thank you again to you, to my great friend Yoko Kato, for supporting this kind of activities. Very impressive. And I wish you all a very nice Sunday, very nice week, and hope to see you soon again, virtually or better personally. So thank you, and shukran, and arigato, and whatever.
Thank you, Professor. Thank you for that open-heartedness to offer the effort for the fellowship or for any short-term courses for the young neurosurgeon, and especially from the Afghanistan and Myanmar. Thank you very much.
We are open for you.
Professor Tadashi Watanabe is there? Or maybe Professor Yokokato, a final remark from you, then we can. Yes.
Thank you very much. Japan is almost 10:30 in the evening, so but I think it was very nice again a webinar, especially the Professor Tadachiba. He made the great lectures, such a very complicated case, hearing very easily. So that means he is a great professional on that area, I think. So maybe in the future, and the Marcos, you can join us the more and more, and also you taught us, you can teach us the more, and also that you can show us some video again. I think especially the developing countries, the young doctors want to see again, I think. So anyway, thank you very much for everybody to join these webinars. Thank you so much.
Thank you. Thank you very much. Thank you, Professor Tadashi Watanabe. Thank you very much for the excellent presentation and educating us. Thank you. Thank you. Bye. Bye.
See you.
Thank you, professors.
Bye-bye.
Thank you, everyone. Bye-bye.
Thank you for coming in person.
Bye-bye.
Sharon,
Thank you.
thank you very much.
Bye-bye.